Hello, friends. Today we'll talk about acute respiratory distress syndrome or ARDS because it continues to be one of the most challenging conditions we face in the ICU. And despite decades of research, the mortality remains high and the practice often varies. And to bring everything into account, the European Society of Critical Care Intensive Care Medicine has released comprehensive clinical practice guidelines on ARDS in 2023, and we'll discuss about this. So allow me to share my slides, please. Just take a moment. So we will talk about the ESICM Guidelines 2023, and I'm Dr. Bharat, Director of Critical Care Department, Kokilaben Hospital, Navi, Mumbai. I'm Examination Secretary-elect of Indian College of Critical Care Medicine, and I was General Secretary of ISCCM in the year 2024 and 2025. So we all know in 1967, Ashbeck found that in 12 sets of the patient who had hypoxemic failure on the post-mortem, there were some alveolar infiltrates and hyaline membranes that are found on the post-mortem examination of the patient who underwent an mechanical ventilation. And they coined the term respiratory lung. And again in 1993, the Willy was the term which was introduced. So the scope of this clinical practice guideline is limited to adult patients and to non-pharmacological support, respiratory support strategies across different aspects of the ARDS, including the COVID-19. And these guidelines are formulated by International Panel of Clinical Experts, one methodologist, patient's representative on behalf of the ESICM. So what they did was the ESICM executive leadership invited three coaches to select an expert panel which will focus on the three broad areas that is ARDS definition, ARDS phenotyping, respiratory support for the care of the of patients with ARDS. And the co-chairs, together with methodologists, divided respiratory support into 7 domains. And the clinical practice guideline addresses 21 questions and which formulates the 21 recommendations. So these are the various domains which they have answered on. We'll take one by one. So let's talk about the definition of the ARDS. We all know the Berlin definition of ARDS in 2012, which takes into account the timing, the chest imaging, and the origin of the edema, and also being classified as mild, moderate, and severe. So what the panel reviewed the current ARDS definition, but they viewed revising the current definition is beyond the purview, and by they also found out the Berlin definition needs patient to be ventilated to have the PEEP to be classified or to be defined as an ARDS. And it complicates the identification and labeling of ARDS patient for whom the HFNO has been used prior to the intubation, which was very widely used in the COVID-19 scenario. So what they proposed is HFNO should be taken into account. We should also look into the resource limited settings and where they spoke about the SpO2 to FiO2 ratio. Though we know the SpO2 is not accurate in the darkly skinned patient, especially in the shock patient, or maybe where the perfusion is impaired. And chest X-ray takes time to reverse back and to improve. So it's not taken. So they were not very sure should CT scan be taken into the definition, and how long. So 10% of the ARDS patient in their study improved over a period of 24 hours. The PF ratio became more than 300. So ARDS is not a transient phenomenon. It's a syndrome which may take few days to week. So also we have to look into how long this patient should have those criteria to be labeled as an ARDS patient. So this new global definition has not been the part of the ESICM guidelines 2023. I've just put it across for the explanation. So, what the difference between the Berlin and the new global definition is in terms of timing, it remains the same. In terms of imaging, it has given the bilateral B lines on the lung ultrasound. Oxygenation SpO to FiO2 ratio has been taken into account, and that's also been classified as mild, moderate, and severe, as you can see here. P, of course, as we spoke, they have taken HFNO into account, and the flow rate more than 30 liters per minute in patient receiving HFNO can be defined as ARDS as per this new global definition. And the exclusion of heart failure and the fluid overload, they've also taken into account pleural effusion and the pulmonary embolism and lung collapses. And severity, as I spoke, it can be also classified as mild, moderate, or severe, even when the patient is on the HFNO. So, non-intubated patients, HFNO is being taken into account. We can also classify mild, moderate, severe as per the SpO to FiO2 ratio. In the intubated patient, it's better to take the PF ratio into account. In the resource limited setting, there's no need of the PEEP or the flow rate. So when you talk of the phenotyping, so how do we define or operationalize an ARDS phenotype? So accurate classification of subphenotype is critical as exemplified by the results of live trial. And the trial randomized patient to either standard lung protective ventilation or a personalized treatment strategy based on radiological subphenotype, whether it's a focal or a diffuse pathology on the chest radiograph. And overall, there was no benefit on the personalized treatment. However, the misclassification of subphenotype resulted in misaligned treatment study. That means patient who had the focal uh, ARDS. In that case, the mortality was high when the low tidal ventilation was followed. So, what is the evidence or for heterogeneity of treatment effect we need to look at? So, in the secondary analysis of HARP2 trial, where the simvastatin was used for the benefit, so what they found in the patient who were the hyperinflammatory case, this is where maybe it was more effective. But in a secondary analysis of sales trial where the rosuvastatin was used, they did not find any difference. But in a certain subgroup group of 4 patients, they found out maybe the rosuvastatin was better. And again, does the phenotyping alter patient response to the PEEP intervention? In ARDS. So secondary analysis of the allular trial identify heterogeneity of treatment effect between hypoinflammatory and hyperinflammatory subphenotypes, and the PEEP strategy adopted. So and same was also found in the observational study of the lung SAFO. What they found was the moderate to high PEEP was more useful when the patient with a hyperinflammatory kind of an ARDS. And again, when it comes to the fluid, a secondary analysis of the fact identified heterogeneity of treatment effect in the patient with hyperinflammatory subphenotype seen to benefit from the liberal fluid strategy in contrast to the hypoinflammatory subphenotype. Now, how does the subphenotyping relate to patient outcome? So the short-term mortality was found to be different between the subphenotypes that are based on the different various areas. So systemic inflammatory response gauged by the plasma proteins. Higher mortality was found in the hyperinflammatory than the hypoinflammatory. When you spoke about the lung radiographic morphology, higher mortality was in the non-focal as compared to the focal group. The patient, when we talk about the recruitability, so the higher mortality was more in the patient who were recruitable than non-recruitable, and the clinical features, higher mortality was found more patient with organ dysfunction, the comorbidities of the acidosis. And we spoke about the longitudinal changes in the respiratory parameters. The higher mortality was found in upward trajectory of ventilator ratio and the mechanical power than as compared to the study strategy. So, what are the research questions we are asking? So, the stability of the phenotypes over time from pre-ARDS through recovery, whether it remains stable or it change as the disease progresses, and whether those phenotypes are reproducible, and there's a repeatability of the certain phenotype as well or not. And also we need to look into the pathophysiological pathway which drives the development of subphenotypes, and the most important, whether precision strategy treatment based on the subphenotypes can improve the outcomes after the ICU discharge as well. So the panel recognized the rising interest and they suggested the further research is required in these areas, which might help us in treating the ARDS in a better way. So when he spoke about the HFNC, that is the high flow nasal cannula, so they compared the nasal cannula versus the conventional oxygen therapy and also nasal cannula versus NIV and CPAP. So when they compare the nasal HFNC versus the conventional oxygen therapy in a non-mechanically ventilated patient, so what they found is the panel recommended that non-mechanically ventilated patient with of ARDS, HFNO receive HFNO as compared to a therapy to reduce the risk of intubation. So when it comes to the intubation and you apply the HFNO, the rate, incidence of intubation goes down, but was unable to make the recommendation for or against HFNO when it comes to the mortality. So what they say is, if we use HFNO in an ARDS patient as comparison to the conventional oxygen therapy, we might cut down the intubation rate, but eventually it has no effect on the mortality. But same is also applied when it comes to the COVID-19 patients. So now the HFNO was compared to the non-invasive ventilation, and again the intubation and the mortality was looked into. So what they found was when we talk about the intubation, there was a moderate level of evidence for mortality and low level of evidence for intubation, and there were no recommendation either in favor or against when HFNO was compared with NIV in ARDS patients. But in the COVID-19 patients, also the no recommendations were made, and there was high level of evidence of no effect when they compared the HFNO versus NIV to reduce the intubation or the mortality. So, but in the COVID-19, they suggest using HFNO and NIV to reduce the intubation, but it has no effect on the mortality. So this is what the forest plot also says. So unresolved questions, what comes in is long-term functional outcome that are missing. It's not clear how long we should be using HFNO and when to convert. And the future trial comparing HFNO to conventional oxygen therapy powered for mortality may be difficult to conduct, and HFNO can best be delivered to maximize effect. We have to look into those further studies, how we can use HFNO in various areas to maximize the clinical effect. Now, when it comes to the NIV, non-invasive ventilation, it was again compared versus the conventional oxygen therapy, and what was looked into the intubation and the mortality. So the no recommendation was made in terms of the mortality, but the weak recommendation in COVID-19 to reduce the rate of intubation. So what it says, when NIV is being compared uh, with the conventional oxygen therapy, there has been no recommendation when it comes to the mortality, but in the COVID-19 patient, it might help in reducing the rate of the intubation, but the low quality of evidence. Of course, the various interfaces are also checked. So patient panels are unable to make a recommendation for or against the use of helmet interface as compared to the face mask interface when NIV was in use. Now let's talk about the tidal volume. So the management of ARDS is oxygen support along with the mechanical ventilation. The mild ARDS can be managed with NIV and HFNC, but moderate to severe ARDS will require mechanical ventilation. So this NAGM paper in 2020,000 has revolutionized the treatment of NIV, and we've been using low tidal volume ventilation. So what panel has also come in a strong recommendation based on the expert opinion for low tidal volume compared to the large tidal volume to reduce mortality in ARDS, and same is true in the COVID ARDS, but the recommendation is very weak. So panel recommend the use of low tidal volume compared to large tidal volume, and strong recommendation based on the expert opinion despite of lack of statistical significance, because they found out this one study which supports it, which supports this, but because this has become the standard of care, it would be ethically not possible to conduct further studies, and this is why this recommendation stays on. So how do we practice it? This is again not part of the ESICM guideline. I'm just introducing in my talk. So we have to look into the predicted body weight as per the formula. See, set the initial tidal volume of 8 ml per kilogram of predicted body weight. Add a PEEP of 5. Select the lowest FiO2 to maintain SpO2 somewhere around 88 to 95. Reduce the tidal volume by 1 ml per kilogram every 2 hours until the tidal volume is 6 ml per kilogram. And the stage two is when you reach the 6 ml per kilogram, measure the plateau pressure. The plateau pressure is more than 30. Decrease the tidal volume further 1 ml per kilogram incrementally till you achieve a target of plateau pressure less than 30. Monitor arterial blood gases. The pH is 7.15 to 7.3. Increase the respiratory rate till you get the pH more than 7.3. If the pH is less than 7.15, increase the RR to 35. If the pH is still 7.15, increase the tidal volume by 1 milligram per kilogram increment till you have the pH of more than 7.15. But what would be the optimal goals? To have the tidal volume of 6 mils per kilogram, plateau pressure less than 30 centimeter of water, SpO2 somewhere in between 88 to 95, with the pH 7.3 to 7.45, and the PaO2 somewhere in between 85 to 55 to 80. So what about the positive and expected pressure in the recruitment manual? So alveoli, LOVES, Express, these are the various studies which has been looked into. And when we talk of the alveoli, which was published in NEGM in 2004, would look into the moderate to severe ARDS, high versus lower peak. No significant difference was found, and more hypoxemia was seen, rescue events are seen in the lower peak group. When it comes to the LOVES, which was again checked in the moderate to severe ARDS, and what was compared was high PEEP recruitment manuals versus the lower PEEP. There was no significant difference in the mortality at 28 days. And higher PEEP improved oxygenation recruitment manual, transiently improving the compliances. Express JAMA, again, which was seen in the moderate to severe areas, where the PEEP was titrated to achieve a plateau of 28 to 30 centimeter of water versus the minimal PEEP oxygenation. Mortality was looked into it for 28 days. Again, there no significant difference. But when the meta-analysis was conducted, which was again published in JAMA in 2010, what it was found, higher PEEP was maybe helpful in moderate to severe ARDS only, but not in other cases. But what the recommendations are, so these are the various ways of doing the uh, finding out the PEEP. It could be the simple method as you go with the low PEEP and high PEEP chart as per the FiO2, or the compliance guided PEEP, esophageal manometry guided PEEP, recruitment influence ratio, which is a novel bedside method for recruitability, identify recruitability and consider higher PEEP when the recruitment if the recruitment inflation ratio is more than 0.5. So look into all this. Panel was unable to make a recommendation for or against routine PEEP titration with higher PEEP or FiO2 strategy versus a lower PEEP FiO2 strategy to reduce the mortality in ARDS patients. So when we speak about the ARDS patient undergoing invasive ventilation, does routine PEEP titration based principally on the respiratory mechanics compared to PEEP titration based on the standard PEEP F5 to table reduced mortality. Again, it was unable to make any recommendation for or against PEEP titration, either guided by the respiratory mechanics or maybe following the chart. We will talk about the use of the recruitment manuals. So recruitment manuals could be the prolonged when we recruit at least for a 1 minute, or it could be the brief when we recruit at least less than 1 minute. So if you look into this, when we look into the hospital mortality versus the test versus control, so hospital mortality was more on the side where the recruitment manual was practiced. And when we look into the barotrauma, again the barotrauma incidence is more when the recruitment manual was practiced. And this is the reason why the recommendations were against the use of the recruitment manual. So panel recommend against the use of the prolonged as well as the brief high pressure recruitment manuals to reduce the mortality in the ARDS patients. So when do we use recruitment manual? This is again not part of the ESICM. I'm just adding to it. So use selectively in recruitable lungs. Avoid if hemodynamic instability is there or the barotrauma is there. And if done, follow the appropriate PEEP to maintain the recruitment. But our trial should increase mortality with aggressive recruitment manual. We need to remember this. What about the prone positioning? So in intubated patient, does prone compared to supine position reduce mortality? So of course, the pooled estimate of randomized trials of proning did not demonstrate the clinical benefit, but the panel based its recommendation for proning on the improved mortality shown in the ProSaver trial, considering the most robust and the relevant trial, where it shown to reduction in the 28-day mortality from 32.8% to 16% when the patient was made prone from the supine position. So, and this is the reason why panel strongly recommend using prone position, especially when the PF ratio is less than 150 and the PEEP is more than 5 centimeter to reduce mortality, even though there's a high level of evidence in favor. So prone positioning, strong recommendation, start proning in ARDS patient early. Early means after stabilization, when your low tidal volume is applied, PEEP is adjusted, and in the end, still the PF ratio is less than 150. Proning should be applied for the prolonged session, that is minimum 16 hours or more, to reduce the mortality. And this recommendation also applies for the COVID-19 patient. But when to stop, we need more studies to do it. But minimum requirement is 16 consecutive hours or more to have the benefit and reduction in the mortality. Awake proning, weak recommendation in COVID-19 patient, reduce the intubation, and not much evidence for the non-COVID-19 ARDS, so no recommendation made when it comes to the awake proning. When you talk of the neuromuscular blockage, there are two major trials and both have a different opinion, Accurace and the Rose trial. Accurace trial found out the patient mortality benefit when the routinely infusion of the neuromuscular blockage was used. But over a period of time, we evolved over a type of the sedation available and the light sedation, the patient being allowed on the spontaneous respiration, being on the sedative method. So the Rose trial came in, which shows against it. So overall, the meta-analysis, they run through the 5 trials, and what they have done is they've recommended against the routine use of continuous infusion of NMBs, that is neuromuscular blocking agents, in moderate to severe ARDS, and no recommendation for the COVID ARDS patient. It's been left according to the physician discretion in specific cases where there's an asynchrony or very high mechanics of use and the patient is not able to tolerate it. So panel recommend against the routine use of continuous infusion of non-muscular neuromuscular blocking agents. Last, extracorporeal life support. So the panel also recommend ECMO change from the prior guideline based largely on the recent ILUA trial, and which reported lower mortality in patients randomized to ECMO, but the finding was not statistically significant. However, the post hoc Bayesian analysis and the panel's pool estimate both suggested that ECMO reduces mortality, and this is why they went ahead with the recommendation, even in the COVID-19 patient, to be using ECMO in certain groups. Accor versus conventional, both the REST trial and the supernova trial are in the research category, and there was higher incidence of the bleeding in the patients where this was being used. So it's been a strong recommendation against the routine use of the Accor. It's only for the research purpose. So this was all about the ESICM 2023 guidelines, all the 21 recommendation when it comes to the definition, phenotype, HFNC versus the conventional oxygen therapy, HFNC versus NIV or the CPAP, NIV versus the conventional oxygen therapy, and then prone neuromuscular blocking agents and ECMO is all what we have discussed, and this is how we do practice. In my next talk, we'll talk about the appropriate PEEP and the recruitment manuals. Thank you very much. Thank you for listening. Thank you. Kindly follow my channel and share the link with all your colleagues to spread the knowledge in critical care and also subscribe. Thank you.